So it's a great pleasure for us and for me to introduce Dr. Carles Pedret. He's a medicine specialist from the University of Barcelona, and he's a specialist in ultrasound diagnosis and ultrasound-guided procedures. His research is about the diagnosis and topography of muscle injuries and the pathophysiology of the tendon. Please.
Thank you very much. So it's a pleasure. It's a pleasure to be here. Thank you, Mario, and all the organizers for inviting me. So I was told to speak about the imaging role in prognosis, but as we have heard just previously, we cannot speak just about one thing when speaking about muscle injuries. So we need to make this prognosis not only about image, we need to speak about the prognosis in general. So mostly about images, and I speak about the role of imaging, but it's a little bit general. So if we want to think, why do we have myotendinous or myoponeurotic injuries? It's quite easy to answer that question. The difficult thing is to apply the solution on that. So this is all about the fatigue and the overload. So if we have a muscle that it's too much overload, it gets an early fatigue, and as there's any material that we can imagine, this curve, it's getting to the left side. So we have the rupture point of that material earlier. So this is the reason why we have muscle injuries in general. So, but this is a problem that we need to solve. And we start solving that problem, we need to get back to 2005, when John Orchard and collaborators said, 2005, it's quite long, make these statements about the return to play scientific criteria after a muscle injury. And they said that this was just about the flexibility and strength test, imaging test, field test, and risk factors control. So imaging test, but by then, have a key role also in the return to play process. But look that this is quite a long years ago, but look that this is completely updated to nowadays. We still use flexibility and strength test, imaging test, field test, and risk factors control. That means that we have improved all the methodology that we can do with that, so better GPS devices, better things, better machines, better devices in terms of imaging, but the key roles are exactly the same. So if you want to know how to treat myotendinous injuries, the first thing is that you need to understand that we don't treat, we just manage. We are managers of muscle injuries and myotendinous injuries. And how we do that? Just to start, we need to start for a diagnosis. It is essential to have an initial diagnosis that needs to be very accurate. And this is very important because we cannot treat or we cannot manage what we don't know exactly what it is. How do we do that? I suggest always in less than 72 hours. To know exactly what we do. The first hours, we need to decrease the inflammation, the acute inflammation, just making a little bit of rest, the things that you all know. But then we need to have a clear diagnosis. The other thing is what we need to do, what we need to know about that diagnosis. And this is the affected muscle or tendon or aponeurosis or whatever, the injury type, the exact location of that injury in the same muscle, and the affected structure. And this is the main point of the image. How can we do that? We can do with imaging and clinical. And this is what we need to do, image and clinical. So here, just for a start, we have two questions. Does the initial diagnosis conditions the return to play plan? For me, the answer is quite obvious, yes. So the initial diagnosis, if you know exactly what we have, you can plan the return to play. If not, it's very difficult. The second one, it's a little bit more tricky to answer. Does imaging conditions the return to play plan? The answer is yes again. But does the imaging conditions? Yes, it does. But should imaging condition the return to play plan? This is the answer that we'll answer at the end of the speech. So for me, no diagnosis, no party. So, what gives us the prognosis after a muscle injury? What gives us the prognosis after a muscle injury, and you will say, okay, that's quite easy to understand. It's knowledge. But do you know what is really knowledge? Let's have a diagram. This is knowledge. So we have data here. If we understand a little bit that data, we have information, but then we need to know what to do without that information that we have. So we have knowledge then. If we understand what we have, we can apply it correctly. So let's see what we can have in there. First of all is understanding the injury according to the sport and the athlete. Muscle and tendon regeneration stages and tissue healing process timings. Injury knowledge, what we said before, anatomy, injury mechanism, risk factors, clinical aspects. Accurate diagnosis with imaging, as we said before. Adaptation to the return to play process. So we step on a return to play planning, but the adaptation is not of the player, it's for the medical team. So we need to know when we need to make a step back, when we can push a little bit more during the return to play process. So the return to play process never has to be closed completely. So we need to adapt to all the things that we can manage during that return to play. And finally, obviously, assessing the re-injury risk, which for me is one of the big troubles that we can find during that process. So let's just speak a little bit just of every one of each then. So understanding the injury according to the sport and the athlete. Let's just speak about the return to play variability in a hamstring common tendon injury. I'm speaking about the exact same injury in both 4 sports. Football player, field hockey, basketball player, and a sprinter. The same exact injury, it can be managed completely different according to the injured athlete and the sport. So, for example, a football player can be more or less return to play in 5 to 6 weeks. A field hockey, 3 to 4. A basketball player, if he's quite smart, it's difficult, but some of them are quite smart. They can make it in 1 to 2 weeks if they know how to move. And finally, if we have a sprinter with the same injury, we are going to more than 9 weeks. And it is just because the mechanics and the conditions of every individual athlete and sport. This is a thing that we need to consider when we're planning the prognosis of every injury. If we go to muscle and tendon regeneration stages, this is very important. As we have been said just previously, we have the degeneration phase, the inflammation phase. Don't avoid the inflammation stage, as we said. Don't give anti-inflammatory drugs that last the first hours, 72 hours. Why? Because inflammation is the key to release some neurotransmitters that can make the regeneration stage to start. So if we avoid the inflammation, we don't have the regeneration, and we reach to the fibrosis. So everybody speaks about fibrosis, very easy. But what is fibrosis really? Let's have a sample. Forget about the cells. Just look at the images. We have here a normal sample of a musculoskeletal sample. And we have here, with a satellite cell here, this is a regenerated skeletal muscle sample. But look at the other side. This is the same kind of musculoskeletal sample with a fibrosis. So this is hardly adaptable, and this is hardly modifiable. So our main goal here, initially, is to avoid a big fibrosis in this scar tissue. So if we simplify, we can say that if we want to say what is a fibrosis, it's an excessive and disorganized amount of connective tissue. We can say like that. The thing is that we have this in the inside part of the hamstring muscle, for example, we need to create a completely new myotendinous junction of the fibers ruptured that attach to that fibrosis scar. So these areas surrounding the fibrotic scar is at high risk during a lot of months after the re-injury, or after the injury, sorry. Because what we know histologically is that, in less than 3 weeks, look day 1, look day 28, and we can still see histological changes here in the sample after a skeletal muscle injury. In less than 3 weeks, a muscle injury is not completely repaired from an histological point of view. And we put players into play or sportsmen into their practice sometimes or most of the times before 3 weeks. But we need to understand that they are not completely healed about that injury. Injury knowledge, anatomy, injury mechanism, we need to understand, and here is where the imaging enters, that we need to understand that this is a tendon, this is aponeurosis, and this tension, this tissue here can be a fascia. Correct me if I am wrong. But I went to the cadaver room and I had a sample of a free tendon, of an intramuscular aponeurosis, and of a fascial tissue, which were continuous in terms of tissue. And I gave that blinded to an histologist. And the histologist said that they were exactly the same kind of tissue. But the only difference is that one is less organized in terms of collagen structure than the others. So this is a matter of thickness. Tendon is more thicker, more organized. Aponeurosis is a little bit thinner, but still very organized. And fascia is a very loose connective tissue at the end of this point. Okay? But we are speaking about a continuum in terms of a structure. So there, what we can have, it's a tendinous or an aponeurotic injury that tears completely that region, a myotendinous or myoaponeurotic injury in that point, a pure intramuscular injury quite far away from any dense connective tissue, because everything is about dense connective tissue. As much connective tissue affected, the worse prognosis. And finally, myofascial or fascial injuries down here. Okay? We need also to look about the injury mechanism. An injury affecting a myotendinous injury or a myoaponeurotic injury in a high energy mechanism will have a worse prognosis than the same injury produced by a low energy mechanism. So we need to study also the injury mechanism of our players. Individual risk factors, extrinsic, intrinsic risk factors for every athlete. So we need to correct risk factors to avoid re-injuries, neuromuscular compensations, and all these things. And finally, of course, the clinical aspect. How is the player clinically day by day? And what does the field test, the clinical test during the first week, and all these things give us in terms of information. Accurate diagnosis, again, with image. Look at these injuries. These are 3 injuries with MRI, because this is an MRI territory. The ultrasound scan, it's a little bit difficult to assess that kind of detail with ultrasound. We have here a complete rupture of the common tendon of the hamstring. So this is a tendinous injury. You can see here the common tendon of the hamstring, but it is completely intact. But the injury is around it. So this is a myotendinous injury. And this one, you cannot see any type of dense connective tissue structure. So this can be considered a pure muscle injury. So all these 3 injuries are affecting the proximal part of the hamstring muscle, especially the biceps femoris. But all these injuries are completely different in terms of prognosis and in terms of treatment, being the worst prognosis, the tendinous one, then the myotendinous, and finally, almost without a return to play, the pure muscular one. The same happens in muscles that have a central tendon or central aponeurosis, like the rectus femoris. We can see a complete disruption with a gap and with retraction of the central tendon of the rectus femoris. We can have a myotendinous affecting the central tendon of the rectus femoris, and we can have an injury quite far away from the central tendon itself that can be considered pure muscular injury. And again, all of these have different prognosis and different types of treatment. So I'm dissecting here a piece of a cadaver, and you can see that I'm not cutting anything. I will just separe things. Look here, I'm separating, okay? Can you see that small pieces of tissue that we have here? Very, very weak. This here, this is the myofascial junction. This weak is the myofascial junction. So injuries affecting the myofascial junction will be of a very, very good prognosis because the tissue is very weak. But we can have a big hematoma. So the hematoma doesn't affect the prognosis at all. It's just a sign of the injury. It's not the problem. Okay? So we can have a big hematoma because the fascial tissue is very expandable, because it's very weak. Again, okay? Look the difference between the myotendinous attachment. This is myofascial attachment. This, don't know how to say that. This is very, very weak. But look this. If you have a rupture, you need here a high energy mechanism to have a rupture in that point, for sure. So this injury has a worse prognosis just by anatomy. And all the injuries, as I said, has completely different in terms of prognosis and in terms of treatment. We need to adapt to the return to play process. If I make a general schedule, I did just for as example, we have the acute stage. We can make the clinical history immediate. We have an clinical exploration every day, every week if we want. We can have the ultrasound scan after 24 hours every day if we want. We need to make an MRI. We can be made anytime, and serial monitoring MRIs if you think that it can be useful. And this is the normal evolution of a muscle injury. But we also need, and we need to understand that we can have, and we know that in terms of imaging, we have a destruction phase, in terms of histology, sorry, we have a destruction phase, then we have a repairing phase between 2-3 weeks, and then we have a remodeling stage of that injury that can go from 2 weeks to 12 months, depending on the injury. And so all these things can be also seen in imaging. So we can really understand what's going on in terms of the quality of the scar tissue that we have. And this is quite interesting and quite important because we know that acute injuries, look here maybe in the T2 signal, which is the bleeding sequence that we can see liquid. This is the acute rupture. Then we have a soft scar repairing stage, which is the critical stage. Be careful with that. If we push too much in that stage is when we chronify that soft scar tissue stage and when we have problems later on. And this stage happens between week 2 and 4, more or less. Then we have an hypertrophic scar stage. And finally, we have a complete scar, thinner and completely functional. We need to be careful in that stage mainly, in the soft scar tissue stage, which is about 15 to 21, 30 days after the initial injury. So we can see during the process when we test a muscle injury that we have different edema patterns. We have published that recently, and we can have a cotton pattern edema. It's like you have with a cotton and you put some kind of liquid just to maculate a little bit, to make up a little bit the injury. We can have a perilesional edema surrounding the scar tissue. We can have an intermuscular edema, or we can have a mixed pattern, which is a cotton pattern and a feather pattern edema. Feather pattern edema is the edema typical that you can see like a feather. That's why it's called feather pattern, I guess. So what we have seen is that cotton pattern edema indicates adaptation to the load that we are applying. A perilesional edema means reparative, ongoing. Intermuscular edema suggests tissue rupture. And mixed pattern, especially the feather pattern edema, means overload. So that means that if we apply an MRI during the return to play process and we see different types of this edema, we can see if, for example, if the player is tolerating correctly the load that we are applying or not. So if we see some feather pattern intermuscular edema, it is recommended to reduce the functional load. Because if you understand what we see, you can stay a little bit more calm than normal. Recognition the muscle edema patterns can help. Chronological times, phases 2 and 3, the soft callus is the critical stage, and the final mature callus can be splitted. And this is not a problem. It's part of the adaptation process. So it's not strange, I'm moving, that we can see something like this after a complete adaptation and the player normally playing, a split in the middle of the tendon. And this, sometimes, without edema surrounding, it's a kind of adaptation. It's not that the tendon remains ruptured. We published that last year in this paper that objectifies 5 radiological findings prior to return to play that we need to consider. One is still a connective tissue gap. We didn't discover anything with that. The callus gap, the intermuscular edema, and the loss of tension for sure, and the interstitial feather pattern edema. So what we saw in a retrospective study is that if we found 3 of these findings prior to the return to play, that means in the last MRI of the return to play made about 15 days before the complete return to play, the risk of re-injuries more than treble the others. So this can be also an interesting point to monitor the return to play and a key role of imaging in that point. And finally, assessing the re-injury risk. So the first we need to understand is maybe we need to revisit the re-injury concept and definition. Because we are using a definition from Marcus Walden Ekstrand from 2011, more or less, which says that the re-injury is an injury of the same type and in the same region than initial injury. But we have seen, if we treat sports athletes regularly, that we can have a big injury in the hamstrings, we recover more or less, but then we have a small injury in the contralateral soleus, and then we have a hip problem, and then we have a glute problem. Are there re-injuries according to the definition? No, of course not. But are they related to the main initial injury? For me, 100%, for sure. And we struggle during month and month and month with a player that cannot play regularly and cannot play at 100% of his capacity. And he is 1 week out, he plays 2 matches, 1 month out, he plays 3 months out, and this is his life from there. So we need to stop that infinite loop of re-injuries. And we know that when there is an injury, there is a decrease of the capacity of the energy absorption. And that means an early fatigue, as we said in the beginning. There is mechanical alterations and neuromuscular alterations that led to an increased re-injury risk. What led to that? A big fibrosis, a muscle atrophy, soft scar chronified tissue, the injury size, and especially pushing so much in the return to play and iatrogenic treatments during the process. Remember that from an histological point of view, in less than 3 weeks, we cannot have an injury completely healed. But early fatigue, mechanical alteration, neuromuscular alteration, if you think about this, you'll see that this is not just about re-injuries. this can happen in every muscle group, in every moment. So if we have compensation, if we have a muscle group which has an early fatigue, if we have neuromuscular alterations, we can have an injury. And here is the point that we need to prevent, what says Olu at the beginning. So, ending. This is not just about anatomy, physiology, imaging, or clinical. These are all the things that we need to understand when planning a return to play process. So it's not just about specific things. We need to think about all of this in a whole. So that's why I wanted not to talk about imaging, because we don't need to talk about imaging, clinical, field, or we need to talk in global, and we need to understand that in a global perspective. So, in my opinion, what should I take home? The best prognosis factor and what gives us more information is the exact location of the muscle injury and the structures that are affected. So the more connective tissue affected, the worse prognosis. Based on a precise diagnosis and initial, athletes with muscle injuries and associated connective tissue lesions should be treated with specific tailored methods. I don't believe in general protocols. Never. So can we have a general protocol? Yes, we can have a general protocol, of course. But don't apply this general protocol to everyone. It's just a general protocol. We need to go much more deeper to every injury and every person. Imaging tests, in my opinion, have a key role in the return to play process, as we see. Ultrasound, it's also very useful, but it has a lot of limitations. So ultrasound is even much more useful if we know exactly when, where, how, and what is useful for. Quality of the scar tissue over time. To see that, the MRI is much more useful than the ultrasound. We have these objective markers to follow, and we have the distribution of the edema patterns after a training session that can guide us in a better way. The most important problems for me are the re-injuries. Be aware always about the soft scar tissue. And finally, it is essential to have an initial diagnosis as accurate, secure, and concrete as possible. And I would say, be careful with classification systems because they never show the whole picture that we have in front. Said that, I always say that excellence is not just evidence or just experience, it's a mix of both. Thank you.
Thanks, Carlos, for the excellent presentation. We have two questions that are nearly the same.
Yeah. From Slido, I will mix them. So in the phase 2, we have to be careful, you said. And how do we monitor that? What are your clinical pearls if we don't have access to MRI or other imaging?
Yeah, that's a good
pain or no pain, or what do you monitor?
That's a good question. When we have a myotendinous or tendinous injury, we need to know, and we all know, that pain, it's just a matter of very few period of time. So after 1 week, 10 days, they are completely pain-free, almost always. So we cannot use the pain as a marker to progress and to be careful in initial stages, because they are free pain completely very, very fast. So what we need to understand is that the histological time, the histological process and the recovery histological process has a time. And we cannot avoid that period of time. So what we need to know is that from day 1 to day 7, more or less, we have the destruction and starting regeneration phase. And then we have an initial of a scar tissue. That initial part of the scar tissue, as you can imagine, does not start with a very big and strong scar tissue. It starts very weak, and it starts developing a little bit of more adaptations to the load we apply during the days. So if we push a little bit more than normal during the period between day 7 and day more or less 15, 20, we know that we can overstress that in development scar tissue, which is weak and which is soft. So this is not about making an MRI every time at 2 weeks to see if there is a soft scar or not, because it's part of the process. For sure it will be. So the thing is that we need to know that we cannot push too much during that period, even everybody wants to. Because in that period is when we can chronify that soft scar tissue. So if the tissue is very weak and the scar tissue is very weak, and we start overstressing that area, we will never allow this tissue to get stronger. So that's the point. We can manage clinically because we know that this is going to happen, because this is part of the regeneration biological process.
Thank you. And are there some questions in the room, maybe? Yes?
Thank you very much. I'm Nick from Zurich. It was a brilliant talk. Former basketball players, in fact.
You were the smart one.
I don't know. My simple question is more based on imaging. How much do you think, very frankly, that the interpretation of MRI or ultrasound is operator dependent?
100%. Well, I never look at a report. Never. I look personally the images, and I made the ultrasound myself. So I never look at the report. If you have to look at the report, you need to trust a lot to the radiologist. You said frankly.
Yeah, absolutely. Nice.
To be frank, here I am for that.
Gracias.
Okay.
Now, the thing is that there is I don't know how to say it politically correct. The thing is that there is a tendency of using too much classification systems. And it's good. I understand that radiologists in their report, they need to use classification systems. But when we read that report, we need to understand that normally, as I said, they never show what's going on there. So if you have a report saying that it's a grade 3C injury, according to the BAMIC, look at the images, because a 3C affecting the proximal part of the common tendon, affecting the middle portion, affecting the intramuscular aponeurosis, or affecting the distal tip of the proximal tendon of the biceps femoris is not the same 3C. So it has completely different approaches. So it's a 3C, yeah, but it's not exactly a 3C in terms of prognosis and treatment. So we need to be careful, because the tendency is say, 3C, 8 weeks. Okay, done. And it's not like that. 3C can be 4 weeks without any kind of problem. We need to see where is this 3C located and which structure really affects or not.
Okay.
Thank you very much. Don't forget, our speakers are always available at lunchtime if you want. Thank you so much.